Okay, let's get down to the bedside. I reckon most of you guys in the private industry, and just remember I work in it still, I'm done 25 years, 4 state, can be pretty comfortable about quality and safety. You have a bunch of great surgeons and clinicians that predominantly work in your hospitals, who provide the quality. If they don't do good operations, things aren't going to work out so well, but they self-select nicely, as you know, as opposed to the public system. And your safety is provided by this bunch of people here. And this is a great crew. This is Bass Ward, Northwest Private, Burnie. You can throw a blanket over the demographic of that staff. And you guys need to not be so comfortable. I'm going to try and make you uncomfortable in this talk. And we're going to start that bit of uncomfortableness straight away with this first bit of video from Four Corners. Peter, if you want to play the video, please.
Promise a top-line education, but they pay dodgy agents offshore to drum up business.
The university managers had personal and financial relationships with the agents.
Turn a blind eye to cheating.
There is an unwritten rule not to fail students.
And turn out poorly trained graduates.
Would they have been safe in a hospital?
No. No way. Education is not an industry.
All right,
what is going on in our universities? Well,
I want you to think about something. Now, I've just purposefully gone for nurses here, but I can do it for medical education as well. We are not teaching our young graduates how to care for patients. We make them do university degrees. That bunch of cohort of nurses never did a nursing degree. They all learnt their nursing at the bedside in hospital-trained courses. And believe you me, I reckon in 10 to 15 years' time, you guys who run these private hospitals are going to have to ramp up on your education of these university graduates, because I don't think they're up to the job. When you lose that cohort of 40 to 50-year-old nurses, we're going to be in trouble. Now, this is my standard disclosure slide, and there's some very important disclosures that need to be made. The first one is that my institutions, the University of Tasmania and the hospital, hate it when I talk, because I talk about embarrassing things and honest things that happen in health. So I have to make that disclosure straight up. Second one is all the thing about clinical pictures, nudity and language, bad language, they're all in today, so you've got that to look forward to. Finally, a pretty big financial disclosure as mentioned by Madonna. I am the founder, all the patents in Patient Track and the associated alert logic, which I'm going to take you through. I have been a director of that company until 2011 when I stepped down so that more competent people could actually run the company, and I am still the single largest shareholder. So that's a pretty big disclosure. So if you don't want to listen to that part of the talk, I'll let you know when it comes up. All right, Tassie. I used to work in the big centres and the flash places, and I was talking to folk last night that didn't really know where I hung out. This is Tasmania. You can see here the major centres of Hobart and Launceston. I actually live in this place called Wynyard, and it's great because the Rex plane comes in there, and it's that type of place where you jump on the plane when you hear the plane overhead. And we serve a population of around 110,000 people on this area called the North West Coast from Devonport through to Burnie. So it's essentially small-time clinical practice, but it is rural regional. And unlike what I can see in the audience here, it is not centre of excellence. Rural regional, along with Aboriginal health, is the lowest common denominator in our healthcare system. We have a department of medicine that is almost exclusively run by locums. Ditto obstetrics. How can you deliver any sort of effective quality and safety and systematic change and improvement in your organisation when you're locum driven and locum run? It's hopeless. And that's the view along the northwest coast with 3 of my daughters posing for the audience. Now, I'm going to basically put to you 2 clinical scenarios. So we're at the bedside now. One patient died, not me, and one patient survived, which is me. And I'm going to focus the middle of the talk around just stuff that came out of that. And then with about 7 or 8 minutes to end, we're going to wrap it all up. So let's just play the first digital video. Oh, there's the one with all the bug blobs. Last year in October, I realised that I had appendicitis. So I was optimistic that this was going to be a quick and straightforward medical issue and that I'd be back on deck pretty quickly.
4 or 5 hours later, he was undergoing a laparoscopic procedure. He was meant to be out of hospital the next day, I think.
But the following morning, I felt absolutely dreadful. I called the nurse in because I just felt lightheaded, and she took my blood pressure, and it was 60 millimetres of mercury. And she did absolutely the right thing. She called the medical emergency team, and here am I lying in bed thinking, yeah, I've done all this fantastic research on medical emergency teams, and I could see the irony of the situation that here it's coming to see me and save me.
I'm just going to monitor your heart rate, Michael.
And then they did an electrocardiograph, an ECG, and that suggested quite strongly that I was having a heart attack.
I had a call from the nurses at the hospital along the lines of, we don't want to worry you, but something's going on with Mike's heart and he's really unwell and we think you better get in here.
I said, I'm not having a heart attack. I don't have chest pain, but the medical emergency team doctor said to me, now look, you just lie there, you be the good patient, I'm in charge here. Look at this ECG. You are not telling me that this is not a heart attack that you're having, Mr. Intensive Care Specialist. You just be the patient.
I got a phone call from Sarah, and I was extremely concerned when Sarah told me that Michael was fainting after his operation. I said that it sounded to me like he was bleeding, that he had ongoing bleeding inside his abdomen. I was even more concerned when I heard that they wanted to do a CT scan on him. You of course have to remember that it's Michael himself that called the CT scanner the donut of death. When a patient is deteriorating really rapidly, the CT scanner can be a very dangerous place because they're well away from the medical staff who can help the patient if something goes wrong. So it's incredibly frustrating, sort of almost yelling into the phone, just, you know. And I look, I can't remember the exact words I used, but I just kept saying to Sarah, don't let them do a CT. Don't. Get the surgeon, okay? Get the surgeon like 5 times.
When I got to the hospital, Mike was extremely unwell.
I just need you to drink these for me, okay? Some contrast so you can go to CT.
I told him what Rob had told me. I was particularly concerned because when I came in, he was about to start drinking green contrast to go into the CT scanner, and I said to him, this is exactly what Rob said not to do.
I had this overwhelming fear that I was going to die, and I could feel the I put together what Sarah had said, that my brother had said, and I looked at my hands and looked at my stomach and said, look, get the surgeon, I am bleeding. And the staff came up to me and said, no, you know, you're okay, your lips still look really pink and, you know, you're fine. And then I had to say, get the fucking surgeon, I am bleeding.
I think it's probably quite possible that Rob saved Mike's life, that phone call saved Mike's life.
I think the episode with his appendix was a very close call, and he knows that. He wound up very unwell. He required, obviously, a return to the operating room. He required a significant blood transfusion. He required to be admitted to his own intensive care unit, which can't be a good thing for a specialist.
Yeah, listen, there's a lot came out of that. Let me tell you, it's never good when your anaesthetist comes into theatre and he's in street clothes and you know the guy and he looks worried. It's not good. And when they opened me up, I crashed on induction, which is just a casual term we use when we induce anaesthesia, and that's because I had 3 litres of blood in my belly. I had 3 litres of blood in my belly because of this. And this is where actually an e-health system or record would have saved me. I'll take you through some pointers on that. Now you can see, I don't know how many cardiologists, but that is not good. That does indicate that you're having an anterior-septal infarct. However, I knew that I had an old ECG that was exactly like that, so I pleaded with the guys to fax over from my office the old ECG, and here's the old ECG, it's identical. I used it for teaching purposes. So I'm pleading with these guys, you know, and they said, we're going to take you to the cath lab. And they'd phoned through to the cath lab, and there was a cardiologist on duty, and it was going to be all go, go, go. 5,000 units of heparin, 600 milligrams of clopidogrel, all straight in. And I got to the cath lab, and the cardiologist there got my first lucky break. He was a fellow New Zealander, so not so interested in billing me. And he said, I don't think this guy's having an infarct, but I don't know what's going on, so let's put him in coronary care. So he puts me in coronary care, and the surgeon drops by and feels my belly and says, I don't think he's bleeding, but we'll do a CT scan anyway. And I remember lifting my head off the pillow to drink that contrast and blacking out with postural hypotension. So I was still running a systolic blood pressure of 50 to 60 with about 3 litres of blood in my belly. And I could actually see my belly distending before my very eyes. I checked my palmar creases, and that's when I said, get the fucking surgeon, man, I'm bleeding. Now, why do I have this abnormal ECG? Well, this may well be surfer's paradise, but I want to highlight some other fantastic beaches that exist. This is in the northern part of New Zealand. And you can see here that I've actually had other things going on with me. And I didn't let on to the surgeon about any of this. You can see a couple of thoracotomy scars there, and that's what my chest x-ray looks like today. In fact, I'm minus 7 or 8 ribs on that side of my chest. And that is all due to the fact that when I was a medical registrar back in Hamilton, I had this cancer here in my lungs. That needed to be resected. In fact, the initial diagnosis with the first bronchoscopy was a hemangiosarcoma, which, ladies and gentlemen, 25 years ago in Hamilton was a death sentence. So they went ahead and resected that tumour. It's very difficult to get out. So difficult that I was left with the complication of a, inability of the residual lung to expand. So I was stuck with these chest drains in, bubbling away, and in the end they decided to do something like out of Game of Thrones and injected air into my belly to try and get the diaphragm to meet up with the lungs. So this was all very complicated. I had a complicated abdomen. So when I said to the surgeon that I had a virgin belly, I thought I had a virgin belly. But he went in there with the laparoscope and all he saw was adhesions from all that damn air that had been injected in there about 25 years ago. And I've got a PhD, 2 fellowships, and I didn't see the importance of telling the surgeon about this past medical history. But if it had been there on a digital record, fantastic. So poor old Paul Cashing goes in there with his laparoscope, dissects his way all the way down to the appendix bed, grabs the appendix and he's out. Only problem is he nicked the inferior gastric artery on the way back. So I've got an arterial bleed, a venous bleed, heparin on board and clopidogrel on board. That is not a good combination. And fortunately, what saved my life was when the nurses did call Paul, he did what? He answered the telephone. And he'd been talking to one of his other mates, because of course I knew all the surgeons there, talking to Brian Hodgkins, who said, you know what, Buist's not having a heart attack, you've got to be joking, man. Get your ass back there. So he was just about to get into his BMW anyway and make the short run to the private hospital. But he got there, got me into theatre, and they had to shut down the theatre next door because you can imagine by now all hell was breaking loose in the hospital, you know. And they shut down that theatre, 2 surgeons, 2 anaesthetists sorted me out. And casually one of the other colorectals just walked by about when they were just closing up and said, trying to kill the director of intensive care, are we chaps? So the irony was not lost on the situation. However, this chap was not so lucky. Let's play the next digital video.
Welcome to the program. I'm Heather Hewitt. The standard of care in our health system has been declared one of the top priorities of the new federal government. But when it comes to people dying in hospitals unnecessarily, an accurate view of the situation is hard to come by. The most recent national report on unexpected deaths in hospitals was published 12 years ago. It estimated that 18,000 Australians die in hospitals each year due to adverse events, including human error. It's a problem that one Melbourne doctor and his hospital are fighting to change. Natasha Johnson reports.
This is a remarkable meeting. Denise Friend is the sister of a man who died unnecessarily, and Dr. Michael Buist is the head of intensive care at the hospital that was to blame. Both were rocked by the unexpected death of 47-year-old Michael Friend at Dandenong Hospital in 2000. Previously healthy, he'd undergone routine surgery for an infection around his lung caused by broken ribs suffered in a car accident 5 weeks earlier. His condition deteriorated overnight and, despite receiving treatment, he died from septic shock and a cardiac arrest.
As a family, we were devastated, we were shocked, we were totally unprepared, and we couldn't believe it had come to this. We thought he'd just have the operation, recover, and he could come home.
Michael Buist was the doctor who'd referred Michael Friend for surgery.
It was with utter horror that I turned up to work and they said, Michael Friend died. And I said, you've got to be kidding. And this was, all of this occurred in the previous night where I had actually been on call. I was on call and slept through this guy's death.
Now that's a fundamental problem, but I'll just walk you through this guy's death. Essentially, when he came back from theatre, there was this phenomena whereby the junior staff on the ward, the nursing staff and the medical staff felt that the patient was okay. They felt he was okay because even though he broached medical emergency team criteria with a heart rate of 131, they felt that the recovery team and the surgeon and anaesthetist must have been happy for him to progress to the ward. Now, the surgical registrar, in fact, was concerned about this patient because he wasn't passing urine. So she said to the intern, if he doesn't pass urine, go and put a catheter on him. So the intern at about 7 or 8 o'clock in the evening goes ahead and tries to do that. Now, this great big muscly guy says to this little intern, go away, I'm not going to let you do that. So there was a very good handover then to the night RMO, who was actually a well-trained, competent doctor, a South African graduate. And this guy, when he was called to see the patient with the first drop in blood pressure, did a fantastic job. He cross-matched blood, gave a fluid bolus, blood pressure came back, and he went about looking after the other 70-odd patients on the surgical floor. And when he was called back with a second drop in blood pressure, again he gave more an appropriate therapy and did the right thing again. He rang the surgical registrar, and the surgical registrar said, well, what's going on? He said, well, look, this guy's been crook ever since he came out of theatre. I've given him some fluid, I've been giving him some blood. Blood pressure's okay at the moment, he's responded to that. Surgical registrar said, well, look, I'll come in early and see him before I start my operating list, you know, I'll be in there at 7 o'clock. This was now about 5 o'clock in the morning. You know, not an unreasonable thing for the guy to say. But in the meantime, the guy loses consciousness, has a cardiac arrest, and essentially we couldn't resuscitate him. Now, that was profound for our organisation, because Denise Friend, who was in the 7:30 report there, and her family were really, really cross. They wanted every junior doctor, every nurse involved in that case cross-examined in the coroner's court down at South Bank in Melbourne by none other than a criminal barrister that they'd hired. But fortunately, we had legal counsel, and I don't know if any of you guys know John Snowden, but boy, I want him on my legal team every time. And this guy said, we are not doing this. So for about 18 months, there was this huge standoff between our legal counsel and the coroner's court. And in the end, we compromised and we said, well, you know, we'll put Buist on the stand and he'll represent the organisation. So I took about a day of cross-examination from this guy. And I had 2 years to think about it. And in that 2 years, I came up with two fundamental things. One was the family wanted to know, why didn't anyone do anything with the abnormal observations? Why wasn't the surgeon notified? Why? And it eventually came to me with what the health minister said. There is no connectivity between the patient and me as a clinician. I slept through that guy's death. And I invented Patient Track. And I'll talk you through that a bit later. Because, part of the problem was I'd done all this fantastic work in the BMJ about how to reduce in-hospital cardiac arrest incidents, blah-de-blah-de-blah. I won't bore you with any of that. But all I want to say is that just standing back, looking at the quality and safety agenda, I can tell you, and I could give you a very academic, boring talk and you'd all be half asleep by now, but the bottom line is that with all of the initiatives that have been put into place, apart from time out and surgical checklists preoperatively, we have not made a blind bit of difference despite the billions of dollars that have been spent on the agenda. And I believe that is the case because we, and I mean you, don't understand your core business. And this is just what you see in the papers around the country. That's quite a recent one. It's when I'm not doing talks and working, I've got 6 kids to look after. But the other thing that came out of the whole the death of Michael Friend was I started to think very deeply about what was going on generally in quality and safety. And we've all been, and who knows the Swiss cheese, James Reason Swiss cheese model? Does everyone know it? Do I need to explain it, or does everyone sort of get it? Because briefly, he looked at industrial disasters. And essentially he said that in a large industry, like when a plane crashes or Piper Alpha or train crashes or anything like that, he looked at them in the UK. He's a professor of psychology at Manchester University. He came up with this thing that we as an industry put up defences, and when you broach those defences, if you can slip your way through a number of broaches, then you'll have a disaster. And we in healthcare for the last 25 years have adopted that model. And I think it's inherently flawed, and this is Palmari's version of that, and I won't take you through that. And Swiss cheese works nicely for industrial accidents. And this is the crash site of I could pick many industrial accidents, but I'm a New Zealander, so it's the DC-10 that flies into Mount Erebus in about 1983 with 283 New Zealanders on board. Now, for a country of 3 million people, what that meant was that just about everyone knew somebody who knew somebody that was on the plane. This was a big deal. Now, the company, namely Air New Zealand, and the Civil Aviation Authority had to undertake a royal commission. And with 2 dead pilots, they instructed council that they were going to come up with 13 identifiable causes of pilot and human error that landed that plane into Mount Erebus. They also instructed council for Air New Zealand and Civil Aviation to admit no mistakes at all for the airline or Civil Aviation Authority. Now, a royal commission that took about 18 months ultimately revealed that the pilots had nothing to do with the crash. Air New Zealand tech crew had altered one of the flight data points in the flight recorder 4 hours before the DC-10 took out of Auckland and had adjusted the flight path from McMurdo Sound 30 miles to the west straight into Mount Erebus. And there was no double checking of that. You also had a couple of pilots that were inexperienced in flying in those conditions. So Reason's model is beautiful. We don't blame the individuals, we look for the system issues. Now, I've challenged that because I am sick of people like, everyone, the whole response to that has been we've got to look for system issues, and that means we've got to come up with policy and procedure. And inevitably that means we have our staff filling out paper forms to say that they've done the job. But we don't really understand, you guys don't, and I don't really understand the culture that goes on at the workplace. And I'm just going to give you some little anecdotes. This is one of my favourites. Who would think that it's a great policy and procedure that if an intern can't get a drip in after two cracks at it, he should call someone else who's more competent? Great for patients, great for the intern, but the anaesthetic registrars who get called, what do you think they think about that policy and procedure? They're not so keen on it. And in fact, we know that some of them were using the other F word when summoned by interns and essentially bullying them. So this guy said, well, look, I'm so scared of the anaesthetic registrars that what I do is I put all sorts of cotton wool balls over the arm so when they turn up to put the drip in, they think I've at least had a decent go at it. Now, you wouldn't know that unless you'd actually started to have a chat to these guys about what really goes on in the organisation. And this next slide is, it's just not the interns and the junior doctors. This is a locum consultant. He reviews a 40-year-old female patient that's been admitted with febrile neutropenia, and the guy is happy that the patient is discharged with a blood pressure. Not only doesn't he call a medical emergency team, the patient has a blood pressure of 86 on 56, can be discharged. Represented about 8 hours later because she just couldn't get off the toilet because she was just so hypotensive, and she's got a ruptured spleen, blood around the spleen. So sadly, guys, I see this all the time as a clinician. And this is a really good example. How am I going for time, Madon? Okay. This is a really good example of, and this is probably the best documented example of staff not doing anything when you've got a really critical situation. Now, your brains are reading that slide, and that's a bad thing to do, because we know, my wife's an educationalist, that you should just listen to me, forget about the slide, and I'll talk you through it. But essentially, so look at me, don't look at the slide. Okay, Merit study looked at cardiac arrests in 23 Australian hospitals, and they documented the biggest series of cardiac arrests across 23 hospitals, about 500 cardiac arrests. Half the hospitals had medical emergency teams, half didn't. So it was a cluster randomised controlled trial. Now, the interesting thing is, though, that what they found is that before these 500 patients had a cardiac arrest, in about 30% of instances, the staff were there taking an abnormal observation and did nothing about it. Even in the hospitals that had the medical emergency team intervention. So if faced with that massive piece of failure at the bedside, you've got to ask yourself what is going on. And that's what's consumed my research, you know, my commercial interests and everything else that I do. And, you know, what's been the Commission's response to that is essentially just to colour code the charts. So it makes it easy for the staff, and a lot of you will be familiar with this. This is Standard 9, Australian Commission stuff. So that when you're in the yellow, you ask for a nurse review, and when you're in the purple, you're meant to call it an emergency team response. So that's how simplistically we actually try to solve the problem. So, you know, they've been doing this now for 5 or 6 years, the Commission, and I have been so fortunate to lift this data from the Royal Adelaide, and it's unpublished data because I was fortunate enough to review the data, and the paper was a dog's breakfast, and I know the guy who's the first author, and I rang him up and said, look, you've got to do this, this and this, the paper's all over the place, it's dreadful. But the data was so powerful, I said, you've got to get this published. What this shows is that we can set a number of rules, like on the paper chart that I showed you on the previous slide, yet the staff, including the 3 levels of call, nurse review, nearly 2,000, clinical review, nearly 800, medical emergency team, nearly 300, they modify the rules. And even with the modification of the rules, look at that failure to comply with policy and procedure at the bedside. 82%, 65%. It's just massive. And likewise in New South Wales, you know, and they've been leaders in the Between the Flags program, those of you from New South Wales will invariably know. And you know, Ken Hillman and the Clinical Excellence Commission have driven that. But they haven't been honest. I found this data buried in a paper about the 2-tier response system for responding to critical situations by Hillman's group, you know, with this guy Anders as first author. And you can see once again here, where they looked at a time sequence and a historical comparison, that even with the medical emergency team and these really well-established hospitals that promote the system, that there's still a significant failure to call when things are not good. And this is where, just to really hammer home the theme, this is actually published, this is an old slide from Daryl Jones at the Austin in Melbourne, whereby, you know, nurses at the bedside exercise a significant of discretion as to whether or not to call for help. And we don't know the rules, the subculture behind that discretion. And this has to be my favourite from my own organisation. Talk about breaking the rules. This guy said, let's just modify the call so that if the patient has a respiratory, don't call the team until the patient has a respiratory rate of 60 or an oxygen saturation of less than about 70%. Hate to say it to all you non-clinical people here, you're dead if you've got those criteria. And that might seem funny, but you're actually having a bad death. You are having a bad death if you're like that when you're dying. And that is what's going on. And I've taken you from the intern through the medium-sized study, and this is the only study in the globe that looks at causation of adverse events in hospitals. And this is the second study done by the Quality in Australian Healthcare authors. Published in 1999, no one ever read this paper. It was a long, boring paper with lots of tables. But the bottom line is, I've highlighted in blue cognitive failures that go on. And my favourite one is about fifth or sixth one down. Again, don't bother looking at the slide, just look at me. Essentially, in 11% of deaths and bad things happening in Australian hospitals, the doctors didn't even turn up. Not interested. So I get back to James Reason, and James Reason himself in about 2000 said this whole business of medicine following what I say is a joke. And if we've got the time, Madonna, I'll just quickly take you through why it's a joke. Because, and when you think about that, I've been in a very roundabout way saying I've come up with this unique theory myself, and it's actually in peer-review publication with the UK journal, which is what I call clinical futile cycles. And every one of you would have had a clinical futile cycle. It might be a personal thing. When things go bad and wrong in your lives, it's amazing how your brain just goes round and round in a cyclical phenomena. Who's had that? It's a very, very common phenomena when you get stressed and things are going bad. You can't actually break your brain out of it. And that's what we find. And the nurse at the bedside has to make a decision about calling the junior doctor. That junior doctor has to make a decision about calling a senior doctor. And it's all these cycles of people making decisions about whether to pick up the phone and make the call. And if we think about some of these adverse events like that, there's a perfect explanation as to what went wrong. Because in my personal instance, the problem, the clinical futile cycle I was in, was that the surgeon was thinking, it's not bleeding, it's not bleeding, it's not bleeding. The cardiologist was thinking, he's now in coronary care, I don't think he's having an AMI, but is there something else going on with his left ventricle that I don't know about? So they're all thinking in their own little circles rather than standing back, which is with a capability that my brother had in Sydney on the phone. He just put two and two together and said, clearly the guy's bleeding. So we find in these critical situations that staff get caught up in what I call these clinical futile cycles. And if you actually think like that, then it's not about the system, it's about the individual. And it's about the fact that we need to educate the individuals and train the individuals for these situations. No amount of policy and procedure will change that. We've got to work on competency at the front, at the coalface. And I've written lots about that. Look, I think in the interest of time I will skip through this, but essentially Reason essentially said that industrial practice is essentially around the fact that you have occasional disasters. When those disasters occur, we look at what went wrong and then we put in rules and policy and procedure to fix it up. However, medicine is more like a system where you have professionals every day in your institutions, in your organisations, making decisions, making little mistakes, making decisions, making little mistakes. It's minute, but it happens all the time. It's background noise. All right, what can we do to try and solve the problem? I am with the Minister big time. The patient has to be a big part of this. And the day one of you guys who runs a healthcare organisation or a private hospital and gives a brochure which has a safety briefing to your patients about how they can help themselves would be fantastic. You know, and there's all sorts of things you could have in that safety briefing for patients. We want to maintain our reputations, don't we? And of course, if you admit that things go wrong, people might not come. But a safety briefing for patients and bringing them into the loop would be great, big time. And I attended a fantastic talk in Paris, you know, where I spoke it myself a couple of years ago, with this whole concept of sharing data. And we're really, privacy legislation is stopping us from doing so much to save our patients. We're bogged down in that bureaucracy. But anyway, I put this thing up because of the fact that I was told to be a good patient so many times when I was sick. I'm going to start a patient movement for the bad patient, which is basically better informed, asks questions and discerning. Right, the next thing to do is education. And I tailor my talks depending on the audience. I'm not going to go down the education path. I actually have digital video on what I do, but I can't do enough in the northwest coast of Tasmania, so I'm going to write a book. It's about how we teach people to think. So I'm in the process of writing this book, and I came up with this mnemonic because, of course, sex sells. So I put that to my wife, you know, saying, you know, I want to send this to the BMJ group of you've got to be joking. You've got to change that mnemonic. It just is not going to fly. So I had to change it to something more sensible. All righty, and I've still got a few minutes before my... Right, okay, good. Because I want to spend a bit of time talking you through the patient track story. Now, 10 years ago, I would have been fundamentally embarrassed to stand up here and actually essentially, I've given you the financial disclosure, so now's the time to leave if you don't want to hear about this part of my life. Because at the end of the day, when you think about it, why was I asleep when Michael Friend died? Why didn't I get a telephone call from someone? If I had got that telephone call, like with Paul Cashin getting the telephone call on me, it would have made a big difference. Because he was not a difficult patient to sort out. He would have needed a central line, we might have needed to have intubated him, we would call the surgeon and got him back to theatre, had his chest cleaned out, and he would have received the appropriate intensive care support that's available in all of your hospitals. But if you don't make that call, you're not in the game. So I came up with this idea that surely if we digitise some of the data at the bedside, then it is available to automatic transmission to whoever you want. And you can write a number of business and clinical rules about how you want that to occur. Now, doesn't that sound fantastic? Back in 2000, I took it to all the people in the then Commission, including the now Chief Medical Officer of Australia, Chris Bagley. I took it to all of the people in Victoria, to people in New South Wales and government departments, took it to a number of private hospital organisations because I needed money to actually do a basic build to test it. And we needed a hospital to actually do the testing. Now, do you think anywhere in Australia back then would come up and say, yeah, let's do that, let's give that a go? No way, man. So I had a few lucky breaks. First one was I had an invitation to Sweden to talk about when I did my 2002 BMJ paper on METs. And those of you who know anything about health IT will know that back then in the UK they were building the super highway for health IT. And every major vendor was in London spending like 25 million quid just on the bids because it was a massive 600 million pound investment by NHS. And of course, you all know it's been a subsequent failure. But at that time, London was the place to be, so I had sufficient contacts from the guy at Deloitte's that I ran with round the Yarra to say, go and drop in and see some of these contacts. And sure enough, when I took it to some of the vendors, they said, yeah, that is unique. This is a clinical app that no one else has. So believe you me, I got back on that damn plane and down into Davies Collison Cave in Melbourne and locked on the IP straight away, back in 2003. That was the easy part. Trying to find somewhere in there to build the thing and to test it was difficult. Fortunately, I met those guys back on the table back there, again through the same contact with the guy I ran with. He said, go and see these guys at MKM. And they were one of two people that we'd sourced that actually had sufficient ability to try and attempt to build a health solution. So I had to put in a lot of my own personal money to get that personal build done in the first instance, with a lot of help from those guys. So this was tough. I'm getting no help from anyone, apart from just a few other people who were actually also runners around the track, but they knew nothing about health, and we just sort of put it together. But then the real lucky break came when, with one of the UK contacts who I'd seen, he said, you know what, there's this guy who's the Director of Medical Services at the Manchester Royal Infirmary. He's ex-Bomber Command. You should talk to him. So I got on the phone and had a chat to this guy, and he got it completely. And Manchester, at the moment, the group of trust hospitals there, like, had 360 cardiac arrests per annum for 100,000 admissions. That's an incidence of 36 per 1,000 admissions. That's off the planet. And they had some fantastic people there. And more importantly, they had something that we don't have in Australia. They had the NHS Innovation Agency Northwest Hub across the corridor. And they were happy to talk to us about money, that squirm issue when it comes to trying to develop this sort of technology. So we got the trial up and running in Manchester, and it worked beautifully. And just on the e-health thing, look at this. The thing is that when you think about IT stuff, you do not think about the people at the front end. And I wanted a solution for the front end nurses and doctors. And this is the 21st of March, me writing out all of my good orders on my patients, drug charts, before I have to come up here to Surfers Paradise. And look at this. This is the national drug chart. Look at it, it's a mess. There's all this beautiful stuff where all the pharmacists have said it's great, where I can put my name, my number, and my signature, but how much space is there to write the damn drug? And the doses in the drug? And those of you who know anything about pharmaceuticals know that all the drug companies now are coming up with combination drugs. How do you fit that in neatly into the tiny bit that I'm meant to? It's a total mess. And that's, of course, something that when I'm in my private rooms that I do in GP land in the community, I get onto medical director. And that is not a problem. And I can't have that communication to my patients in the private system. Just how crazy is that? And you should see what my kids can do with their iPads. So I've got to give credit. It's not only me that's been hard at work and doing the hard yards here. A group in Oxford who've started up part of our competition in the UK with their company Nerve Centre. And Gary Smith, right from the very start, he published early papers like I did. That's a group from Portsmouth, and their company is Vital Pack. So I've tried to do due credit to the other people who've worked in this very difficult space. And this is one of Gary's old slides. And you can just see the minute you start to digitise this stuff, you can do something for your front-end coalface troops. You can start to get data on your core business and make some sense of it. And you can start to merge together a whole lot of things. So essentially there's two ways to go about your IT strategy. You can buy a legacy system like Cerner that say they'll do everything, but then when you want to build in the changes, they'll charge you a fortune. Or you can go the way of New Zealand and the UK, where we'll just put in a spine and you'll buy best-of-breed actual solutions for e-prescribing radiology systems, and we'll just get them all in the one portal. And I think that's the way to go. And we're just one part of that space. And this is just old slides from the old days when we had to struggle to do the initial trial, and we've now got, essentially we've moved on to the fact that that's the type of reporting you get. And we have built in stuff like this, because what I wanted from the company was quite simply someone that listened to our consumers. And acute kidney injury is a big problem, and our group at Western Sussex were right on to this. And getting an acute kidney score, and I've had 2 patients die recently where there's been undetected acute kidney injury, not under my care but in our organisation. And here we have an AKO status as an alert. You can build that in with a lab feed, comes up as a nice front end, and we've had about £1 million grant to work on that from the NHS. So there's all sorts of things you can do in terms of helping your front end people. And task management. We all know about task management. You guys probably don't do ward rounds, but I do. I don't have a piece of paper here. I'll have my junior doctors after me, and what are they doing? They're writing on scraps of paper about what I've told them to do for Mrs. So-and-so and Mr. So-and-so. And then once they've finished their ward round, they sit down with their scraps. Have any senior doctors here or ex-senior doctors? Yeah, am I on the money here? Absolutely. So and that's what I used to do too. So they're writing away, writing it all down, and then they'll go away and do their tasks. I mean, why can't we help them? They're our frontline troops. Why can't we give them a system that at least allows them to allocate their tasks and priorities much better? Well, I've seen enough observation charts, but you can just see how they're much needed. This is the study. Got published in Critical Care and Resuscitation 4 or 5 years ago. Essentially, we showed a dramatic improvement in clinical response to the bedside for the sick patient. And for the sickest patients, we improved that response to nearly 100%. We actually dropped the cardiac arrest incidence to 0, but that was in the study, 4 study wards, but that was not statistically significant. And of course, this is just something that I give credit to some of my opposition, which is from the Vital Pack group, where they showed that they could detect what you probably already know, that in your organisations, people don't actually do observations when you want them to, namely at night. But it's great to have that information. It's great to know when you need to allocate your staffing resources. And just in case, this is work that was published in abstract format at the International Forum in London last year, where you can see at Manchester we've significantly dropped the mortality rate in that organisation with the introduction of the solution. Right. Change of pace, ladies and gentlemen. I want to talk about listening and not listening. And I have 6 children, but in fact I have one that passed away before she was born. And this has been significant for me because I've spoken about this at a number of conferences for the last 3 or 4 years. It took me 3 or 4 years to get the strength to do it. And I think I'm over it now. So this is the last time I'm going to walk you through this. Can we just play the video?
I guess as an obstetrician, not to mention a brother, Mike rang me on a Thursday afternoon to tell me that Sarah had been to the obstetrician. The obstetrician had listened to the baby's heartbeat and had been very reassuring.
And then by the Friday morning I was really concerned. I felt that there was something going on. When I went in to see the obstetrician, Again, she listened for the heartbeat, and when she found the heartbeat, said to me, and it was probably in jest, but it was inappropriate, "See, you're making it all up, aren't you?" The obstetrician organised for me to go to have a scan. However, the baby didn't move for the whole scan and she wasn't seen breathing. And the person who did the scan concluded that he thought she was just a lazy baby. The following morning, I said to Mike I was still really concerned, so we rang the obstetrician and she said to go into the Monash, fetal unit, which we did. And by the time we got in there, it was too late.
So, from Hannah's death, one of the things, like I said, I've done, that it's been another significant, huge moment for me, is that I try to teach people to listen to their patients. And that's part of the education thing. And that's why I'm writing the book. Because I don't think we listen to our patients. And I don't think we ask them the right things. And I don't think we pay enough human attention to the patients. So despite the technology work, despite the research, I fear that with our graduates, we are putting people into the system that don't know how to care, and we haven't taught them how to care, and we haven't role-modelled caring. I remember that I was a medical registrar when I had all of those thoracotomies. I think I went back to theatre 2 or 3 times for the surgeon to try and fix up what was going on when they took out that tumour. And I remember going into theatre, you get wheeled in. I was in hospital for about 6 months. I've done a lot of time as a patient. I remember getting wheeled into theatre, and it was about... There wasn't really any clear plan. Nothing had really been explained to me about what was going to happen. They were just going to try and have a look and try and fix it up. And I remember just for no reason, I think if you've been a patient and you've been frustrated with what's going on, I just started crying and recover, and in the waiting area before you go in. And this theatre nurse just came up and held my hand and just said, "It's going to be okay." We don't do that anymore with our patients. That bunch of 50-year-old nurses do, but the people coming through don't. They don't know how to do that. That defines quality. Thanks for listening.
What a terrific presentation, Michael, and thank you. And Michael has left 10 minutes at the end to answer our questions, and I'd love you to join in this discussion. We do have clinicians, we have administrators, so we've got a mic over that side of the room. Just raise your hand and we'll bring one to you. Michael, you talk about clinicians, you talk about administrators, you talk about junior staff, you talk about the patient. So there's a lot of things go wrong at a lot of levels. What can people in this room go back and do that would materially make an almost immediate difference?
You can actually practice it tonight. You can practice it when you go home and see your partner, lover, husband, boyfriend, girlfriend, whatever. You can ask a thoughtful question. Because one of the things I say to the students is that, and I take an interest now in my students, my 4th years, and I just say, just tell me why you're up on the northwest coast, why you want to do medicine and all that stuff. Take an interest in those people. So what I have decided to do is that I put that teaching priority ahead of going to meetings with you folk. I lock that time in every week, that 90 minutes, where I spend time with these 4th year students. And you guys can all do that. You can all take under your wing someone who's just started the organisation, who's a junior nurse, junior allied health, junior administrator, and show that even though you're the CEO, the GM or whatever, you care. You know that they might be a single mum who has to, with the pressures around that or whatever else. Just show that you care with the people around you, because then you want those people, when they go to the patient and the bedside, you want them to care. That's not going to make great neurosurgeons, great cardiac surgeons. There's a whole lot of issues around. I could have done this talk totally differently. But if you can just show that you care and are prepared to spend time with some of the people who are at the grassroots, at the coalface of your organisation, you will hear the stories of the intern who had to put all the cotton wool balls. And you'll start to learn about what's going on in your organisation.
Thank you. Our first question here.
Michael, thank you very much. Malcolm Passmore. You posed the dilemma of nursing training. We moved into the university system in 1985. I'm old enough to have trained in the whole hospital-based system.
Yeah.
So I was brought up with that caring model and that hands-on trade type training. How do we build a relationship, collaborate, communicate with the tertiary organisations to try and talk about the curriculum? Because they will still tell you that their students, and I'm talking about nursing, that their students come out prepared to manage the hospital system.
Who believes this gentleman? Well, no one backs, I've got to say, I think that there's going to be one of two things that are going to happen. I reckon we're getting screwed with the tertiary sector with respect to... And look, I teach in it. I have tried to fail a paramedic student for overt plagiarism, i.e. he literally downloaded an assignment and submitted it. Didn't even try to tinker around the edges. It was like overt plagiarism. Now, in my view, that should just be an automatic fail. But the amount of paperwork and shagging around and stuff I had to do around that one bad bit of performance was phenomenal. And try and fail a medical student. I haven't started on that. Try and fail a medical student. So we have this fundamental problem, and of course you'll remember. I remember back in Hamilton, and when we had the critical care nurse for the course for the nurses. That picture's that one with the big wave is just to show that if you think surfers' paradise is surfers' paradise, it is. But if you want real surf, it's all happening down in Tassie.
Is that you in the picture?
Yeah. No. This is going to be a fundamental problem, I believe, because I think that, and I could have filled 15 minutes of the talk talking about medical education, because we now teach our doctors and examine them on a thing called an OSCE. Who knows what an OSCE is? Structured clinical examination. And we get to assess them on 5 to 8 minutes of, examine the thyroid, stitch this up. We don't do the long case where it's sit down in front of this mother and take a paediatric history and we're going to mark you after 30 minutes. So they don't spend time doing that. They don't spend the time at the bedside as students talking to their 85-year-olds. And one of the other jokes I pass off all the time is that you get these kids and say, here's this woman now I want you to examine, she's an 85-year-old lady. They haven't got the first idea about how to position the pillows, the blankets, to look after modesty, to look after curtains. So these guys, half of them who consider themselves sexual experts, or experienced or whatever, can't even make an 85-year-old woman comfortable in bed. And that's because we don't teach that anymore. And I think that gets back to your point. And the other thing is that there's a dumbing down of people within the healthcare system, because with that course in Hamilton, as the ICU registrar or medical registrar, I had to prepare 2 or 3 lectures to give to these people. So that was good for me. I had to be part of the system. And we have relegated all of that to the tertiary sector. And I think there needs to be a conversation around that, because those guys charge a fortune and I don't know that they're providing what you guys as an industry need.
Michael, you've also talked about senior clinicians and how they could change perhaps in the way they listen and in what they do. You've got CEOs here going back to talk to senior clinicians. How much are you talking about a cultural change in people's organisations, and how much do you see this as a procedural change?
Well, I reckon the CEOs in the audience will know that if they go and talk to their clinicians and say they've heard this guy Buist and he thinks this and that, they'll just say, who cares? You know, this is how we're doing it here. I think there needs to be a generational change, and we need to, one of the reasons I put so much emphasis on my fourth years, and with our medical emergency program that we had at Dandenong and Monash, I emphasised all of the education with the first year doctors. That's because that's when they're thinking hard and they want to be good and all that, very important time in their lives and careers. So I didn't worry about the registrars and the consultants. But if you stay at it long enough, 10 years later, you've got this guy walking up to you in the car park and he says, I'm the new urologist. I was your intern. That was great, that stuff you gave us. You've got them converted if you spend time with them young. You're not going to change these old guys and just... I've actually got something in press about this whole bullying and harassment thing with the Royal Australasian College of Surgeons. You know, the potential for jokes are endless. But, you know, I think that I think that highlights the difficulty of change at that high level. And yet, you know, my interaction with the College of Surgeons is that they're a very attuned, responsive body like that down in Spring Street in Melbourne. But out in the peripheries where you've got these guys who, who aren't close to that, it's a totally different story. And I fear that it's not till they retire out and the new ones come through that it'll take that degree of change.
You admitted that you were partly at fault. As the patient, you didn't reveal all your abdominal issues.
Yeah.
When we're looking this afternoon at the patient being the centre of the care model, how much responsibility lies with the patient?
Well, I reckon if the number of times you have adverse events and things that go wrong, and the patients will say, I was trying to tell the nurse or I was trying to tell the doctor. I mean, who's had that? You know, most of you will. We were trying to say, we were trying to get the message out.
Okay, ladies and gentlemen, a terrific presentation. Thank you for the generosity of your time, but also your comments.